The journey through life's later stages brings with it a heightened awareness of health, particularly the intricate workings of our cardiovascular system. While discussions often center on lifestyle choices, genetic predispositions, and the visible tolls of stress or diet, a more insidious threat may lurk in plain sight. The very medications intended to safeguard our well-being. This is not a discourse on obscure ailments or complex surgical interventions, but rather a critical examination of common pharmaceutical agents, often FDA-approved, doctor-prescribed, and ubiquitous in medicine cabinets worldwide. For individuals in their senior years, specifically beyond the age of 60, these daily staples can quietly, incrementally, and often without overt warning, escalate the risk of severe cardiac events, including heart failure, stroke, and sudden cardiac arrest. The alarming reality is that a significant proportion of older adults remain oblivious to these potential dangers. Prescriptions are frequently renewed on autopilot. The subtle manifestations of adverse drug reactions are misattributed to the natural processes of aging and perilous polypharmacy. The simultaneous use of multiple medications is routinely overlooked within fragmented healthcare systems. This critical assessment aims to illuminate these often hidden risks, drawing upon extensive research, expert consensus, and publicly available data encompassing economics, trade, and geopolitical trends in healthcare. We will systematically examine 5 classes of medications that warrant a second, more cautious look for the aging heart. Our approach is grounded in empirical evidence, eschewing sensationalism for clarity and factual accuracy, presented in a formal and professional register suitable for both corporate strategy discussions and academic scrutiny. The global demographic shift towards an aging population underscores the urgency of this topic. Nations worldwide are grappling with the complex interplay of increased life expectancy, rising chronic disease burdens, and the escalating costs of pharmaceutical interventions. The pharmaceutical industry, a multi-trillion-dollar global enterprise, continuously innovates, yet the long-term safety profiles of widely adopted drugs in specific demographic cohorts, particularly the elderly, demand ongoing rigorous reevaluation. Healthcare systems, often designed around acute care models, struggle to adapt to the nuances of geriatric pharmacology, where physiological changes drastically alter drug metabolism, distribution, and elimination. This often leads to a disconnect between prescribing patterns, patient experience, and optimal health outcomes. The implications extend beyond individual patient health, impacting national healthcare budgets, workforce productivity, and the broader societal capacity to care for its aging citizens. Understanding these risks is not merely about individual health management. It is a vital component of public health strategy and informed policymaking in an increasingly aging world. Our exploration begins with a class of medications almost universally present in households globally, perceived as benign remedies for everyday discomfort, yet capable of placing a significant, silent strain on the aging cardiovascular system. This category, non-steroidal anti-inflammatory drugs, or NSAIDs, represents a cornerstone of pain management for millions. Ibuprofen, naproxen, and diclofenac are household names, readily available over the counter and instinctively reached for when confronted with the myriad aches and pains associated with aging, from arthritic joints to persistent headaches or back discomfort. Their accessibility and familiarity often breed a sense of unquestioning trust. However, for individuals beyond the age of 60, this common solace can quietly transition into a serious cardiological concern. The therapeutic efficacy of NSAIDs stems from their ability to inhibit cyclooxygenase, COX enzymes, thereby reducing the production of prostaglandins, which are key mediators of pain and inflammation. While this mechanism effectively alleviates symptoms, prostaglandins also play crucial roles in maintaining physiological homeostasis, particularly in renal and cardiovascular systems. In younger, healthier individuals, the body often possesses sufficient compensatory mechanisms to mitigate these systemic effects. But with advancing age, physiological resilience diminishes. The primary mechanism by which NSAIDs pose a risk to the aging heart is through their impact on renal function and fluid electrolyte balance. The kidneys, critical regulators of blood pressure and fluid volume, undergo natural structural and functional changes with age, even in the absence of overt kidney disease. The glomerular filtration rate, GFR, progressively declines, and renal blood flow is reduced. This age-related attenuation in kidney function, often subclinical and not always reflected in routine lab tests, significantly alters the body's ability to process and excrete sodium and water. NSAIDs interfere with the prostaglandin-mediated vasodilation of renal afferent arterioles, leading to renal vasoconstriction and a reduction in renal blood flow. This effect, coupled with direct inhibition of sodium and water excretion, results in fluid retention. The physiological manifestations of this fluid overload are often subtle and easily dismissed by older adults and even healthcare providers. Symptoms such as bilateral ankle swelling, peripheral edema, a sensation of shoes feeling tighter, increased fatigue towards the end of the day, or a general feeling of heaviness in the legs are frequently attributed to just getting older. Yet, these are often red flags, indicative of increased intravascular volume. This excess fluid directly increases the workload on the heart. For older adults, particularly those with pre-existing conditions such as hypertension, coronary artery disease, or latent heart failure, this added cardiac preload and afterload can precipitate or exacerbate congestive heart failure. The elevated blood pressure associated with fluid retention further burdens the already compromised cardiovascular system, increasing the risk of adverse events. Moreover, the prolonged use of NSAIDs has been consistently linked in epidemiological studies and clinical trials to elevated systemic blood pressure, the onset or worsening of hypertension, and a heightened risk of cardiovascular thrombotic events, including myocardial infarction and ischemic stroke. These risks are dose-dependent and cumulative, meaning that the longer and more frequently NSAIDs are consumed, the greater the likelihood of adverse cardiovascular outcomes. The insidious nature of these effects is particularly concerning. Patients often do not perceive their kidneys struggling or their heart working harder. The symptoms are vague, easily conflated with the general malaise of aging, leading to delayed diagnosis and intervention. The danger of NSAIDs is compounded by potential interactions with other commonly prescribed medications for older adults. For instance, the concurrent use of NSAIDs with diuretics, often prescribed for hypertension or heart failure, can create a dangerous physiological synergy. Diuretics aim to reduce fluid volume, but NSAIDs counteract this effect by promoting fluid retention, thereby diminishing the efficacy of the diuretic and potentially leading to a paradoxical worsening of fluid overload. Furthermore, the combination of NSAIDs with ACE inhibitors, or angiotensin receptor blockers, ARS, frequently used for blood pressure control and cardiorenal protection, can form a triple whammy scenario. This combination significantly increases the risk of acute kidney injury, particularly in vulnerable elderly patients, who may already have compromised renal function due to age or comorbidities. The vasoconstrictive effects of NSAIDs, coupled with the renal hemodynamic changes induced by ACE inhibitors, ARBs, can lead to a precipitous drop in GFR, resulting in rapid renal deterioration. The economic ramifications of NSAID-related adverse events are substantial. hospitalizations due to acute kidney injury, exacerbated heart failure, and cardiovascular thrombotic events contribute significantly to healthcare expenditure. A study published in the Journal of the American Geriatric Society highlighted that adverse drug events, including those related to NSAIDs, are a leading cause of hospitalization among older adults, often translating into prolonged hospital stays, increased readmission rates, and higher overall healthcare costs. From a trade perspective, the global market for analgesics, heavily dominated by NSAIDs, reflects their widespread consumption. However, growing awareness of their long-term risks, especially in an aging global population, points towards a potential shift in prescribing patterns and an increased demand for safer alternatives. This shift could impact pharmaceutical research and development, steering investment towards novel pain management strategies with more favorable geriatric safety profiles. Geopolitically, countries with rapidly aging populations, such as Japan and many European nations, face immense pressure to develop and implement robust pharmacovigilance programs and clinical guidelines that specifically address the safe use of medications in older adults. For older adults, the goal in managing pain should not be to endure discomfort, but to achieve relief through strategies that do not inadvertently create more significant health challenges. Regular NSAID use in individuals over 60 necessitates a candid discussion with a healthcare provider to reevaluate its appropriateness. While complete cessation may not always be necessary, reducing frequency of use to an as-needed basis rather than daily, or exploring alternative agents, can significantly mitigate risks. Safer pharmacological alternatives for certain types of pain may include acetaminophen, though its use also requires careful consideration of dosing and potential liver toxicity, especially in patients with hepatic impairment or those consuming alcohol. Topical NSAID preparations, such as gels or patches, offer localized pain relief with minimal systemic absorption, thereby reducing cardiovascular and renal risks. Non-pharmacological interventions are increasingly recognized as cornerstones of pain management in older adults. These include comprehensive physical therapy programs tailored to address specific musculoskeletal issues, heat or cold therapy, transcutaneous electrical nerve stimulation, TENS, acupuncture, and therapeutic exercises such as stretching, yoga, or Tai Chi, which improve flexibility, strength, and balance. Psychological approaches, including cognitive behavioral therapy for chronic pain, can also equip individuals with coping mechanisms and reduce pain perception. The critical message here is one of informed choice and proactive medication management. NSAIDs, while seemingly innocuous and effective, demand a higher level of scrutiny in the aging population. A multifaceted approach, integrating medication review, exploration of safer alternatives, and engagement with non-pharmacological therapies, represents the optimal strategy to manage pain without compromising cardiovascular health and overall independence. This deliberate approach contributes to a more sustainable healthcare ecosystem, reducing the downstream costs associated with preventable adverse drug reactions and enhancing the quality of life for seniors globally. Transitioning from pain management, our next focus shifts to a class of medications often prescribed to alleviate the pervasive challenges of insomnia and anxiety conditions that frequently escalate with age and life transitions. We refer to benzodiazepines, a group of pharmaceuticals that, while offering immediate relief, can insidiously erode cognitive function, compromise physical stability, and ultimately undermine the independence of older adults. Medications such as lorazepam, temazepam, and diazepam are frequently prescribed for their anxiolytic, anxiety-reducing, hypnotic, sleep-inducing, and sedative properties. For many seniors grappling with sleepless nights or overwhelming anxiety, these pills can feel like an indispensable lifeline, offering a reprieve from distressing symptoms. The immediate gratification of a full night's sleep or a calmed mind is compelling. However, beneath this therapeutic veneer lies a complex pharmacology that, in the aging brain, can lead to profound and often irreversible detriments. Benzodiazepines exert their effects by enhancing the activity of gamma aminobutyric acid, GABA, the primary inhibitory neurotransmitter in the central nervous system. By binding to GABA-A receptors, they increase the frequency of chloride channel opening, hyperpolarizing neurons, and thereby reducing neuronal excitability. This generalized dampening of brain activity is precisely why they induce sedation and anxiolysis. However, the aging brain exhibits altered pharmacokinetics and pharmacodynamics with respect to benzodiazepines. Hepatic metabolism, particularly oxidative pathways, slows down with age, prolonging the half-life of many benzodiazepines and leading to drug accumulation. Additionally, the aging brain demonstrates increased sensitivity to CNS depressants due to changes in receptor density and neuronal pathways. These physiological shifts mean that standard adult doses can have disproportionately potent and prolonged effects in older individuals. The consequences of this amplified central nervous system depression are multifaceted and deeply concerning for the geriatric population. One of the most immediate and tangible risks is a significantly increased propensity for falls. Benzodiazepines impair psychomotor function, reducing reaction time, coordination, and muscle control. This impairment is particularly acute during nocturnal hours, when residual grogginess from a sleep aid can lead to disoriented movements, unsteadiness upon rising, and a higher likelihood of tripping or losing balance. Falls in older adults are not merely minor accidents. They represent a leading cause of severe injury, hospitalization, and a catastrophic loss of independence. Hip fractures, head injuries, and other trauma resulting from falls can initiate a cascading decline in health, often leading to long-term institutionalization, reduced quality of life, and increased mortality. The economic burden associated with fall-related injuries in seniors is enormous, encompassing emergency room visits, surgical interventions, rehabilitation costs, and long-term care expenses. Healthcare systems globally expend billions annually treating fall-related injuries, a substantial portion of which could be mitigated through judicious medication management. Beyond the immediate physical dangers, benzodiazepines are also implicated in a more insidious erosion of cognitive function. Long-term use has been consistently linked to memory impairment, mental fog, reduced executive function, and a higher risk of developing dementia. The very neural pathways responsible for memory consolidation and information processing are suppressed, leading to subtle yet progressive cognitive decline. Patients often experience difficulty concentrating, forgetfulness, and impaired recall, symptoms frequently mistaken for normal age-related cognitive changes or the early stages of dementia. This misattribution delays identification of the medication as the root cause, perpetuating harmful prescribing patterns. Studies have indicated a correlation between prolonged benzodiazepine use and an elevated risk of Alzheimer's disease and other forms of dementia, though the precise causal mechanisms remain areas of active research. The geopolitical implications of this issue are significant. As global populations age, the prevalence of anxiety and sleep disorders is projected to rise, potentially increasing benzodiazepine prescriptions. This creates a public health challenge, requiring national strategies for geriatric mental health that prioritize non-pharmacological interventions and promote judicious prescribing practices. Regulatory bodies face the complex task of balancing access to necessary medications with the imperative to protect vulnerable populations from long-term harm. A particularly challenging aspect of benzodiazepine use in older adults is the development of dependence and the associated withdrawal syndrome. The body gradually adapts to the presence of these medications, leading to tolerance, where higher doses are required to achieve the same therapeutic effect. Attempting to discontinue benzodiazepines abruptly can precipitate a severe withdrawal syndrome, characterized by rebound anxiety, intractable insomnia, restlessness, irritability, muscle spasms, and even seizures. This fear of withdrawal often traps individuals in a cycle of continued use, even when the medication's benefits have waned and its adverse effects are manifesting. The irony is poignant. A medication initially taken to improve sleep and alleviate anxiety may, in the long term, paradoxically exacerbate these very conditions, while simultaneously compromising cognitive clarity and physical stability. The critical message here is not to advocate for immediate, unsupervised cessation, which can be dangerous. Instead, it underscores the paramount importance of a comprehensive medication review with a healthcare provider. For individuals currently taking benzodiazepines, especially long-term, a carefully planned, slow, and supervised taper is often necessary to minimize withdrawal symptoms and ensure patient safety. This process requires patience, close monitoring, and often the support of a physician or pharmacist experienced in deprescribing. Beyond cautious withdrawal, the emphasis must shift towards safer, evidence-based alternatives for managing insomnia and anxiety in older adults. Cognitive behavioral therapy for insomnia, CBTEI, is widely regarded as the first-line treatment for chronic sleep disturbances. Unlike pharmacological interventions, CBTI addresses the underlying thoughts and behaviors that perpetuate insomnia, offering sustainable improvements without any adverse drug effects. Its efficacy has been proven to be superior to, or at least equivalent to, sleep medications in many studies, with more durable results. For anxiety, a range of non-pharmacological approaches offers significant benefits. Mindfulness-based stress reduction, MSRR programs, incorporating meditation and yoga, have demonstrated efficacy in reducing anxiety levels. Regular physical activity, even moderate exercise such as walking, can significantly improve mood and reduce anxiety. Breathing exercises and relaxation techniques provide immediate coping mechanisms. Furthermore, certain classes of antidepressants, particularly selective serotonin reuptake inhibitors, SREs, can be effective for generalized anxiety disorder and often have a more favorable long-term safety profile regarding falls and cognitive function in older adults, though they too require careful monitoring for side effects. The distinction between the prescribing practices of primary care physicians and specialists often plays a role here. Primary care providers, under pressure to manage multiple conditions in a short consultation, may resort to readily available pharmaceutical solutions. Geriatric specialists and psychiatrists, however, are typically more attuned to the unique vulnerabilities of older adults and are more likely to recommend or implement non-pharmacological strategies. This highlights a systemic challenge in healthcare training and resource allocation, where insufficient emphasis on geriatric pharmacology and behavioral health interventions can lead to suboptimal outcomes. The economic advantages of non-pharmacological approaches, though requiring initial investment in therapeutic services, can lead to substantial long-term savings by reducing medication costs, preventing falls and hospitalizations, and improving overall health span. In essence, the little white pill that promises restful sleep or a calm mind, while offering temporary solace, may inadvertently be chipping away at the very foundations of an older adult's balance, mental acuity, and cherished independence. This knowledge empowers individuals and their caregivers to engage in informed dialogue with their healthcare teams, advocating for strategies that prioritize long-term holistic well-being over immediate, potentially deceptive, relief. Our journey through potentially hazardous medications brings us to a class ubiquitously prescribed for gastrointestinal discomfort: proton pump inhibitors, or PPIs. These medications, often viewed as a benign solution for heartburn, acid reflux, and indigestion, represent a silent drain on the body's vitality, potentially impacting not only the heart and bones, but also the broader metabolic and immune systems of older adults. Brands like omeprazole, pantoprazole, and esomeprazole are household names, offering profound relief from the burning sensation and discomfort associated with excessive stomach acid. For many, a single daily dose transforms mealtime from an ordeal into an enjoyable experience, making these medications feel nothing short of miraculous for acute symptoms. However, the critical caveat that often goes unheeded is that PPIs were primarily designed for short-term use, typically for durations of 4 to 8 weeks, especially in conditions like active ulcers or erosive esophagitis. Yet, millions of seniors globally continue to take PPIs for months, even years, without regular reevaluation of their necessity. This prolonged, uncritical adherence can lead to a cascade of serious consequences, many of which subtly undermine the health and resilience of the aging body. The most overlooked long-term effect of PPIs stems from their fundamental mechanism of action. They potently suppress gastric acid secretion. While this effectively alleviates reflux symptoms, stomach acid is not merely a source of discomfort. It is a vital component of the digestive process, crucial for the absorption of several key nutrients. When gastric acid levels are chronically suppressed, the body's ability to extract essential minerals and vitamins from food is severely compromised. Prominent among these are calcium, magnesium, iron, and vitamin B12. The implications of these deficiencies are particularly dire for older adults. Low calcium levels directly impact bone mineral density, significantly increasing the risk of osteoporosis and debilitating fractures, especially hip fractures. A hip fracture in an elderly individual often marks a turning point, frequently leading to prolonged disability, loss of independence, and even increased mortality. The economic and social burden of osteoporotic fractures is immense, taxing healthcare systems with surgical costs, rehabilitation, and long-term care expenses. Magnesium deficiency, another common consequence of long-term PPI use, can manifest in a variety of ways, including cardiac arrhythmias, muscle cramps, weakness, fatigue, and dizziness. These symptoms are often vague and can easily be misattributed to other age-related conditions, further delaying proper diagnosis and intervention. Low iron levels can lead to iron deficiency anemia, causing chronic fatigue, weakness, and reduced cognitive function, while vitamin B12 deficiency can result in macrocytic anemia, peripheral neuropathy, and severe neurological and cognitive impairments, including memory loss and confusion, again mimicking symptoms of natural aging or dementia. The cumulative effect of these micronutrient deficiencies is a gradual erosion of overall health and functional capacity, leading to a diminished quality of life. Beyond nutrient absorption, stomach acid plays a crucial role as a primary defense mechanism against ingested pathogens. Its highly acidic environment effectively neutralizes bacteria and viruses entering the digestive tract. Chronic acid suppression by PPIs compromises this innate immune barrier, rendering the body more vulnerable to gastrointestinal infections. One particularly concerning risk is an increased susceptibility to Clostridioides difficile infection. C. A virulent bacterium that causes severe diarrhea, abdominal pain, and dehydration, often leading to prolonged hospital stays and, in severe cases, fatality, particularly in frail older adults. The geopolitical context here is intriguing. As medical tourism and global trade in pharmaceuticals expand, the accessibility of PPIEs in many developing nations, often without strict regulatory oversight or comprehensive patient education, could exacerbate these long-term health challenges on a global scale. This underscores the need for international collaborations on pharmacovigilance and guidelines for rational drug use. Furthermore, emerging research has linked long-term PPI use to other serious health outcomes, including kidney disease, dementia, and adverse cardiovascular events. While more extensive and longitudinal research is still ongoing to fully elucidate the causal pathways and definitively establish these associations, the accumulating evidence points towards a pattern where the benefits of prolonged PPI use in older adults may be increasingly outweighed by significant, often silent, risks. These studies, drawing from large population cohorts and sophisticated epidemiological methodologies, are prompting a fundamental reevaluation of PPI prescribing practices worldwide. The nuanced understanding of PPIs is crucial. They are unequivocally effective and often essential medications for specific acute conditions such as active peptic ulcers, severe erosive esophagitis, or Zollinger-Ellison syndrome. In these contexts, their short-term benefits far outweigh potential risks. The problem arises when a temporary therapeutic intervention morphs into an unchallenged, permanent habit, driven by automatic prescription renewals and a lack of patient or physician reevaluation. The transition from active treatment to maintenance therapy often lacks a clear, evidence-based rationale for indefinite use, especially in the absence of ongoing symptomatic relief requirements or high-risk conditions like Barrett's esophagus. The economic implications of this overuse are substantial. Beyond the direct cost of the medications themselves, which runs into billions annually worldwide, the downstream costs associated with treating PPI-induced adverse events, fractures, infections, hospitalizations for electrolyte imbalances, or C. difficile, add a significant burden to healthcare systems. This phenomenon of prescribing cascades, where the side effects of one drug are treated with another, often begins with a seemingly innocuous prescription like a PPI and can lead to complex polypharmacy. For any individual, particularly an older adult, who has been on a PPI for more than a few months, initiating a dialogue with a healthcare provider is imperative. This discussion should critically assess the continued need for the medication. There are various strategies for deprescribing PPIs, ranging from dose reduction, switching to an on-demand regimen where the medication is taken only when symptoms flare, or a complete taper under medical supervision. Gradual tapering is often recommended to avoid rebound acid hypersecretion, a transient phenomenon that can occur upon abrupt cessation and mimic a return of original symptoms, thus falsely reinforcing the perceived need for the drug. Non-pharmacological interventions also play a pivotal role in managing gastroesophageal reflux disease, GERD. Lifestyle modifications, such as dietary adjustments, avoiding trigger foods like spicy items, caffeine, and fatty foods, weight management as obesity increases intra-abdominal pressure, elevating the head of the bed, and avoiding meals close to bedtime, can often provide significant symptomatic relief and reduce the reliance on PPIs. These interventions, while requiring patient commitment, offer sustainable solutions with no medication-related side effects. The philosophical underpinning of this reevaluation aligns with a broader shift in geriatric medicine towards a more holistic and patient-centered approach, prioritizing functional independence and quality of life over mere symptom suppression. This means understanding that relief today, achieved through medication, should not come at the expense of an older adult's bone strength, cognitive clarity, or overall resilience tomorrow. The proactive management of pups is a crucial component of optimizing health outcomes in the aging population, contributing to a more efficient and patient-focused healthcare model globally. Our fifth critical examination leads us to a paradox often encountered in healthcare. Medications designed to protect the heart can, under specific circumstances, become a source of risk, particularly in the aging demographic. We refer here to various classes of heart and blood pressure medications. For millions of older adults, these pharmaceuticals are indeed life-saving, meticulously calibrated to lower elevated blood pressure, reduce cardiac workload, stabilize heart rhythms, and improve overall cardiovascular function. Their role in mitigating the progression of chronic cardiovascular diseases and preventing acute events cannot be overstated. However, the efficacy of these medications is profoundly influenced by the dynamic physiological changes inherent in the aging body, meaning a regimen that was optimal at 55 might prove detrimental at 75. The very cure can, in the wrong dose, combination, or context, transform into a subtle but significant hazard. Let's dissect some commonly prescribed cardiovascular medications. Diuretics, often colloquially termed water pills, are foundational in treating hypertension and heart failure by promoting the excretion of excess fluid and sodium. While effective, in older adults who often have reduced renal reserve and altered fluid balance, diuretics can precipitate dehydration, significant electrolyte imbalances such as hypokalemia or hyponatremia, and orthostatic hypotension, the lightheadedness or dizziness experienced upon standing. This tired, lightheaded feeling is frequently dismissed as a consequence of aging, when in fact, it can be a direct result of a diuretic pulling too much fluid from a vulnerable system, increasing the risk of falls and subsequent injuries. The economic burden of fall-related hospitalizations due to medication-induced orthostasis is immense. From a geopolitical perspective, the widespread availability and affordability of generic diuretics make them a staple in healthcare systems globally, especially in resource-constrained settings. However, the lack of rigorous follow-up and electrolyte monitoring in these contexts can lead to widespread, unrecognized adverse effects in elderly populations. Calcium channel blockers, CCBs, another common class, work by relaxing blood vessels, thereby reducing blood pressure and easing cardiac workload. While effective, in some seniors, CCBs can lead to bothersome peripheral edema, swelling in the legs and ankles, bradycardia, slowed heart rate, and fatigue. The non-dihydropyridine CCBs, like verapamil and diltiazem, directly suppress cardiac contractility and conduction, posing a risk for excessive bradycardia or heart block in susceptible elderly patients, particularly those with pre-existing conduction abnormalities. Beta blockers, a cornerstone of cardiovascular therapy for conditions ranging from hypertension to heart failure and arrhythmias, similarly present a complex risk-benefit profile in the elderly. These medications slow the heart rate and reduce myocardial oxygen demand. However, in older adults, this slowing effect can sometimes be excessive, leading to symptomatic bradycardia, shortness of breath, especially in those with underlying chronic obstructive pulmonary disease, even with cardioselective agents, cold extremities, and reduced exercise tolerance. A particularly dangerous interaction occurs in individuals with diabetes. Beta blockers can mask the physiological symptoms of hypoglycemia, low blood sugar, such as tremors and palpitations, delaying recognition and treatment of a potentially life-threatening event. The inherent physiological transformations that accompany aging are central to these challenges. Arterial stiffness increases, baroflex sensitivity, the body's ability to regulate blood pressure rapidly declines, and renal function, as previously discussed, diminishes. The way the aging body metabolizes and excretes drugs is altered, and drug distribution volumes can change due to shifts in body composition. For example, decreased lean mass, increased adipose tissue. These changes mean that drug doses that were appropriate and well tolerated at 55 can become supratherapeutic and harmful at 75, often without any dose adjustment by prescribers. The issue is further compounded by the phenomenon of polypharmacy, the escalating problem of polypharmacy in older adults, where multiple medications for various conditions are simultaneously prescribed, amplifies the risks associated with cardiovascular drugs. An individual might be on a beta blocker, a diuretic, a statin for cholesterol, an antiplatelet agent, and potentially other medications for rhythm control or other comorbidities. This complex pharmacological cocktail creates a fertile ground for drug-drug interactions, additive side effects, and an overall systemic burden that can overwhelm the aging body. This medication overload often manifests subtly: a gradual increase in fatigue, mental fog, unsteadiness, or a general feeling of being off. These symptoms are frequently dismissed as inevitable consequences of aging, masking the underlying contribution of the medication regimen. The economic implications are stark. Adverse drug reactions, ADR, are a leading cause of emergency department visits and hospitalizations among older adults. Many of these hospitalizations are directly attributable to poorly managed cardiovascular medications or their interactions. This not only incurs direct healthcare costs, but also impacts the individual's quality of life, often initiating a downward spiral into frailty and loss of independence. The trade aspect relates to the global pharmaceutical market, where an increasing number of novel cardiovascular drugs are introduced, adding to the complexity of prescribing decisions for an aging demographic. Ensuring rational drug use and robust pharmacovigilance is paramount to mitigate the risks associated with this expanding therapeutic landscape. The challenge lies not in discarding these critical medications, which indeed save lives and prevent devastating events, but in consistently reevaluating their appropriateness and efficacy in the context of an individual's evolving physiological state. The practice of simply renewing prescriptions without a thorough review of their continued need, optimal dosing, and potential interactions with other drugs is a systemic failing. Healthcare providers must adopt a proactive, rather than reactive, approach to medication management in older adults. This includes regular, comprehensive medication reviews that consider the patient's current health status, functional goals, and overall quality of life. The objective extends beyond merely controlling numbers on a chart, such as blood pressure or heart rate readings. The true aim is to preserve the patient's cognitive sharpness, physical stability, mobility, and independence. If an older adult, or someone they care for, is taking multiple medications for blood pressure or heart disease, several critical questions must be posed. Are the current doses still appropriate for their age and current health status? Are these medications working synergistically or antagonistically? Are there any side effects being experienced that could be attributed to the medications rather than solely to aging? This critical scrutiny can lead to dose adjustments, simplification of medication regimens, or even deprescribing of unnecessary drugs. The right heart medication, appropriately managed, can indeed extend and enrich life. Conversely, a poorly managed or inappropriate combination can insidiously erode health, independence, and well-being, piece by piece. This necessitates a collaborative approach between patients, caregivers, physicians, and pharmacists, fostering an environment of shared decision-making and continuous reassessment to ensure optimal, safe, and person-centered care for the aging heart. The geopolitical challenge for nations worldwide is to develop healthcare policies and educational programs that embed this dynamic approach to geriatric pharmacotherapy into standard clinical practice. Having delved into specific classes of medications, we now arrive at the most pervasive and arguably the most dangerous pharmaceutical challenge confronting older adults globally: polypharmacy. This term, defined as the concurrent use of 5 or more medications, transcends the risk of any single pill, representing an intricate web of potential interactions, additive side effects, and systemic overload that poses an unprecedented threat to senior health and independence. The scale of this phenomenon is staggering. Studies consistently indicate that nearly half of all adults over the age of 65 take 5 or more prescription medications daily, with a significant subset consuming 10 or more. This complex pharmacological burden is not typically the result of malicious intent or egregious medical error, but often emerges from a confluence of factors within a fragmented healthcare system. An individual may be prescribed a medication for hypertension by their primary care physician, another for hypercholesterolemia by a cardiologist, a sleep aid by a different specialist, a pain reliever by an orthopedist, an acid reducer for gastrointestinal symptoms, and perhaps an antidepressant for mood, alongside a battery of vitamins and supplements. Each prescription, individually, might be clinically justified for a specific condition. However, these drugs are rarely tested together in clinical trials, especially not within the unique physiological landscape of an aging individual. The fundamental danger of polypharmacy lies in its cumulative effect. Every additional medication introduces new variables into the body's already complex biochemical systems, exponentially increasing the probability of adverse drug reactions, ADRs, and harmful drug-drug interactions. The kidneys and liver, the primary organs responsible for drug metabolism and excretion, experience a natural decline in function with age. This reduced metabolic capacity means drugs linger longer in the system, accumulating to higher concentrations and exerting prolonged effects. The heart, too, bears a greater burden, as it must contend with the systemic effects of multiple pharmacological agents simultaneously. The manifestations of polypharmacy are often insidious and easily misattributed. Patients may report chronic fatigue, increasing unsteadiness, forgetfulness, altered digestion, or subtle mood shifts. These symptoms are frequently and often mistakenly dismissed as unavoidable aspects of just getting older. This misattribution is particularly perilous because it masks the true etiology of decline, preventing appropriate intervention. The insidious spiral often begins with one medication causing a side effect, which is then mistakenly diagnosed as a new condition, leading to the prescription of yet another drug to treat the side effect. This prescribing cascade propagates, burdening the patient with an ever-increasing pill count, diminishing their quality of life, and paradoxically moving them further away from optimal health. A significant proportion of these daily prescriptions, moreover, are no longer medically necessary. They may have been initiated for an acute condition that was resolved, for a short-term therapeutic goal that was met, or based on guidelines that have since been updated. Without a systematic, ongoing review process, these legacy medications persist in the patient's regimen, contributing to the overall burden without offering commensurate benefit. This quiet accumulation of unnecessary or inappropriate drugs places immense strain not only on the individual's physical and cognitive faculties, but also on their emotional and financial resources. It can steal mental clarity, diminish energy levels, and critically undermine the very independence that older adults cherish. The economic consequences of polypharmacy are staggering. Adverse drug reactions, often preventable, are a leading cause of emergency room visits and hospital admissions among older adults, accounting for billions of dollars in healthcare expenditure annually in developed nations. These costs extend beyond direct medical care to include long-term care, rehabilitation, and the indirect costs of lost productivity and diminished quality of life. From a trade perspective, the global pharmaceutical market thrives on the development and sale of new drugs. However, the unchecked proliferation of these drugs without a concurrent focus on medication stewardship in an aging population creates a significant public health challenge impacting national health budgets and resource allocation. The geopolitical dimensions are evident in countries like Japan and various European Union members, which are at the forefront of managing rapidly aging populations. Their healthcare systems are pioneering strategies, from national medication reconciliation programs to enhanced roles for clinical pharmacists to address the profound challenge of polypharmacy and ensure the sustainable delivery of geriatric care. The solution to the complex challenge of polypharmacy is not a blanket cessation of all medications, which could be equally dangerous, but rather a systematic, thoughtful, and patient-centered review of every prescribed drug. This process, often referred to as medication optimization or deprescribing, requires the expertise of a skilled healthcare team, typically involving a physician, a pharmacist, and often other allied health professionals. A comprehensive medication review involves meticulously going through a patient's entire medication list, including over-the-counter drugs, supplements, and herbal remedies, with the aim of identifying outdated prescriptions, reducing or discontinuing unnecessary medications, and adjusting doses or regimens for those that are still needed. Tools like the Beers criteria for potentially inappropriate medication use in older adults, or the START criteria screening tool of older persons' prescriptions, screening tool to alert doctors to write, are invaluable in guiding clinicians through this process, helping to identify drugs that pose a high risk for adverse effects in the elderly or those for which there is no clear indication. The outcomes of successful medication optimization can be genuinely transformative and life-altering for older adults. Patients frequently report significant improvements, reduced dizziness and fewer falls, a palpable increase in energy levels, enhanced focus and cognitive clarity, and a general sense of feeling more like themselves again, sometimes for the first time in years. This reduction in the medication burden often translates into fewer hospital visits, a decrease in the incidence of adverse drug events, and an overall improvement in functional status and independence. The philosophical shift underpinning this approach is profound. It moves from a disease-centric model, where each symptom is addressed with a new pill, to a patient-centric, holistic model that prioritizes the individual's overall well-being, functional goals, and quality of life. It acknowledges that health is not always about adding more interventions, but sometimes about thoughtfully letting go of what no longer serves the patient. This patient-centered approach to deprescribing requires careful communication, shared decision-making, and addressing potential patient concerns about stopping medications they have taken for years. For individuals over 60, or for their caregivers, this is a call to proactive engagement. If you or a loved one is taking 5 or more medications, scheduling a comprehensive medication review with your primary care physician or a specialized pharmacist is not just advisable, it is critical. This involves asking hard questions. Do I still need this medication? What are the potential side effects? Are there non-pharmacological alternatives? Could any of my symptoms be caused by my medications? Advocating for oneself in a complex healthcare system is paramount. The global healthcare community, recognizing the pervasive and costly impact of polypharmacy, is increasingly investing in initiatives to promote medication, stewardship, and improve geriatric pharmacology education. Policymakers are exploring strategies such as incentivizing medication reviews, integrating pharmacists more deeply into primary care teams, and developing electronic health record systems that flag potential drug-drug interactions or inappropriate prescriptions for the elderly. These efforts are not merely about economic efficiency, they are fundamentally about respecting the dignity and preserving the independence of our aging populations. The most dangerous pill, ultimately, is not a single drug, but the silent, often unrecognized, cumulative burden of too many medications. Understanding this empowers individuals to take control of their health narrative, ensuring that their medication regimen genuinely contributes to, rather than detracts from, a vibrant and independent later life. It is a shared responsibility, a dialogue between patient and provider aimed at optimizing health, preserving autonomy, and fostering a better quality of life in our golden years.